In this video, we will discuss oral health changes that accompany mechanical ventilation in the critically ill, the 4 components of comprehensive oral care, and recommended oral care delivery techniques for the intensive care patient. Oral care is an essential element of patient care in the intensive care unit. However, oral care delivery in mechanically ventilated adults may not always receive the attention it deserves. This lack of recognition may be attributed to the high-pressure, highly technological critical care environment and competing care demands. Adults admitted to the intensive care unit are commonly older, unable to meet their own oral health needs, and may have undiagnosed or untreated oral disease. Research to date indicates a strong relationship between poor oral health and infection-related problems, including ventilator-associated pneumonia, both during and following intensive care. The prevention and management of oral disease has thus become a public health priority and a critical intervention in the intensive care unit. Soon after ICU admission, oral health can rapidly deteriorate due to dehydrating side effects of common medications, placement of oral tubes, and a reduction in normal saliva production. These alterations to the oral environment contribute to 3 distinctive oral health changes. These include low or absent salivary flow, also called xerostomia, inflamed or ulcerated tissues, also referred to as mucositis, and accumulation of oral and dental biofilms containing communities of disease-causing bacteria. Human saliva plays a key role in maintaining oral health through its antimicrobial, lubricating, and buffering properties. Decreased production and inadequate distribution of saliva during critical illness can result in mucositis, which is characterized by inflammation of the mucous membranes, tongue, and lips. Visible changes can include cracked lips, a rough, fissured, biofilm-laden tongue, mouth sores, and severe halitosis. Low saliva states may also contribute to the accumulation of oral debris and plaque, thus providing the ideal environment for bacteria to multiply. This will lead to development of biofilms. Biofilms are implicated in the development of dental caries, gingivitis, and periodontal disease. Importantly, the longer biofilm remains in the mouth, the more harmful it becomes. With gingivitis, the gums become red, swollen, and can bleed easily. When gingivitis is not treated, it can advance to periodontitis, in which infection breaks down the bone and tissues that support the teeth. The bacteria found in biofilm is scientifically linked to a number of systemic diseases, including pneumonia in mechanically ventilated patients. Comprehensive oral care in the intensive care unit aims to control biofilm development and treat low salivary states. To perform comprehensive oral care, you will need the following: a cup of sterile water, water-based lip and mouth lubricant, a soft bristled toothbrush, sponge-tipped touthettes, a suction device. You may also require a disposable mouth prop. The 4 components of comprehensive oral care are oral assessment, toothbrushing, application of mouth and lip moisture, and oral suctioning to remove excess secretions and debris. As the first step of the assessment, complete hand hygiene and don personal protective equipment that follow institutional requirements for infection prevention and control. Elevate the head of the bed to at least 30 degrees so the patient's oral cavity is easily examined and oral secretions are not aspirated. Introduce yourself to the patient and describe the purpose of the oral exam. Ensure the patient is informed of the ensuing steps prior to every stage in the oral care bundle. Consider lubricating the lips with water-based products before mouth care to improve comfort during the insertion of oral care devices. Clinical assessment of the oral cavity using a standardized approach is important in the planning and delivery of oral care. Assessment should include the condition of the lips, tongue, mucous membranes, and teeth, the amount and tenacity of saliva, and pain presence. Proceed with the examination in an anterior to posterior fashion, beginning with the lips, then moving to the tongue, gums, mucosa, and teeth. Retract lips and cheeks for the initial look. A pen light and tongue depressor may be essential for a complete assessment. Look for changes in color, presence of swelling, redness, ulceration, and any dry or malodorous areas which may indicate the presence of bacteria. If the patient is able to self-report, ask about oral dryness and pain in the mouth or throat. If the patient is unable to tolerate the examination of the oral cavity, evaluate for pain presence and provide analgesia before moving on to the next step of comprehensive oral care. A critical component of an evidence-based oral care bundle is the prevention of biofilm formation through toothbrushing. The use of a soft bristled brush can reduce biofilm formation even below the gum line. The modified Bass brushing technique being demonstrated here is the most effective method for mechanical removal of dental biofilm. Place a soft toothbrush moistened with sterile water at the gum line at a 45-degree angle. The brush is then wiggled 3 to 5 times and then moved away from the gum surface. Brush 1 or 2 teeth at a time and be sure to complete the entire line of teeth. Brush the outsides and insides of the teeth in a similar manner. Once this has been completed, brush the chewing surfaces of the teeth and the tongue where accessible. For patients who do not have teeth, it is important to gently brush the gum mucosa. Brushing should be performed twice a day and for no less than 2 minutes at each toothbrushing. Use of a water-soluble moisturizer every 2 hours is important for the maintenance of healthy lips, tongue, and gums. Dryness and cracking of the lips, tongue, and gums provide regions for bacterial proliferation. A water-soluble moisturizer allows tissue absorption and added hydration. Moisten a toothette with moisturizer or sterile water. Apply the moistened toothette to the lips, tongue, and mucosa. Oral and subglottic suctioning is recommended as the last step to oral care while taking into consideration the amount of secretion production. Suctioning can minimize aspiration of contaminated secretions into the lungs. Gently insert the suction device along the side of the patient's mouth into the oropharynx and advance to reach the subglottic space. Suction the accessible secretions. Suction for only 5 to 10 seconds to avoid direct contact with the oral mucosa. At the completion of comprehensive oral care, make sure to document the procedure and report any abnormal findings. If your patient is biting, agitated, uncooperative, or having difficulty opening their mouth, consider using a disposable mouth prop designed for this purpose. A single-use mouth prop may be fashioned by wrapping several tongue depressors together using gauze and tape. To insert a mouth prop, wiggle the device in between the back teeth. Don't insert between the front teeth as you risk chipping or breaking the teeth. Turn the mouth prop so that its wider aspect is between the back teeth. This allows for more room to provide oral care. Repeat this insertion technique to clean the opposite side of the mouth. In this video, we have identified the importance of oral care for critically ill ventilated patients and described the reasons why comprehensive oral care is a critical intervention.